Good, good afternoon to everybody. Now, our presentation of IC is based on the artificial intelligence. As you all know, it is a future of our ophthalmology. But here we are trying to present the comparison between what we have conventional approach in ophthalmology previously and at present scenario of artificial intelligence based management. So, not wasting the time, I will first ask the first speaker, Dr. Aditya Anand. He is presenting on the basic introduction of artificial intelligence. He has passed his MBBS at JSS Medical College, Mysore, post-graduation from RIO Minto Hospital, Bangalore. Now he is DNB student at Arvind Eye Hospital, presented papers at state level and national level, and the key speaker of artificial intelligence IME 84 in Midcon, Bangalore. Now I will request Dr. Aditya Anand to present his paper.
Good afternoon, everyone. So basically, I'm going to discuss about the basic introduction of artificial intelligence. Artificial intelligence is the simulation of human intelligence process by machines, especially computer systems. So the system acquires, the three processes which is involved in the system is learning, reasoning, and self-correction. So learning by how we divide is the acquisition of information and rules for using the information, reasoning, using rules to reach approximate or definite conclusions, and self-correction is the self-validation. So every industry, like whether it's medical or any kind of industry, it needs artificial intelligence for its growth and it's for improvement in the basic output. So the big players which is involved in the artificial intelligence, which provides a support for the data, as you can see, are the big tech giants. There's Amazon, Google, IBM, NVIDIA, so many things are there. And even the startups company are helping us in promoting the concept of artificial intelligence, helping us in all scenarios. So artificial intelligence, basically it has following components as cognitive system, neural networks, planning, robotics, machine learning, natural language processing, perception, knowledge, and all these are the components of the artificial intelligence. So we will discuss about the basic concepts. So we'll go in step-by-step manner. So we'll start with the basics. What is the objective of this artificial intelligence? To automatically detect and measure pathologic features in images of the eye. And what are the methods which involve? It analyzes pixels, labels, and group of pixels in fundus photographs or 3D dimensional voxels. We call voxels in OCT images in some way. But it has the variety of approaches. So first, the simplest form of AI is the simple automated detectors by pattern recognition. It is the simplest form of AI, and here programmers give the software mathematical descriptors of the features to detect, and it's a rule-based algorithm for searching these patterns on incoming images. So in this, what happens, if you give an image to this software or system, the basic thing is already it's in the pattern recognition. It is stored in the pattern recognition. So if that picture matches with the pattern recognition of that software, it becomes a positive hit and it recognizes that image. And it is a diagnostic indicator. So second is the basic machine learning. In this approach, this algorithm is given with some basic rules about which the disease feature look like, along with a training set of images from affected and unaffected eyes. So algorithm is used to examine the image to learn about the differences. And advanced machine learning, it becomes by the computing different units of information, which we call in neurons, which mimic the multi-layered structure of the visual cortex. So the neural networks actually, if you give some basic input, so it works by the information which is stored in its hidden layer, and finally it detects the output, which comes as the final decision. So it learns to associate multiple specific inputs of disease, feature detectors, and results in more accurate output diagnosis. So as you can see here is an illustration of supervised learning, the way computer algorithms are taught to recognize pattern. There are so many fundus OCT pictures which are stored in the whirlpool of data. It is in the hidden layer structure. As we give the basic input we give through our study, and it analyzes itself by the hidden layers. So finally giving us to the output through going through its various hidden layers and coming up to its correct guess or wrong guess, which the computer itself decides basis on the algorithm stored in it. So this deep learning with the convolutional neural networks, why it is called as a deep learning? So deep learning is because there's a multiple interconnected layer of neurons, and they perform their tasks through self-correction and repetition. So yeah, and and deep learning actually it's a core component of AI, because it comes to comes to intelligence like a human performance it has seen actually, and that's why it comes closer to resembling thinking like us. So there is, but the problem with AI is its black box concept. So now what happens is that Google has developed a successful system called as a Google Brain in 2016. So up till now we are all discussing about the supervised learning algorithm, because whatever the data we have stored it in, so we can analyze and compare it with those data, and it gives the results. But now something is called as black box system, which is unsupervised. So what happens is here, so deep learning algorithm, Google teaches itself to correctly identify diabetic lesions in photograph, even though it was not told what the lesions look like, on the basis of their own search results or something. So if you do a meta-analysis of this deep learning, so what the output results we get, you can't say, like, sometimes what happens, even if the algorithm is not stored in its software or its data, the results comes good, and sometimes the results comes correct, and sometimes the results are not correct or as false. So that is why the unsupervised black box systems, what happens, it actually arrives at the correct results most of the time, even though it is not it is very unsupervised, even though it is not stored. So because of this, the unsupervised black box system unsettles some specialists with fear due to unsupervised approach, but it definitely facilitates others which are not yeah. So there are two things where, like, these are lesion-based disease detection. So how the black box works, it's a simple assessment. So you can see the lesion-based data, the fundus photograph is quality assessed, and if the results according to this deep learning algorithm with the convolutional network is okay, so this results comes okay and it gets passed. So now it will come to the lesion detection, anatomy localization, it will automatically detect, and finally the assessment arrives to DR positive, DR negative, like that. But black box disease detection, what it did, nothing is stored in the data, it's like only unsupervised, and finally it arrives at the correct results. But this can't happen all the time, so that is our limitation. So AI as a next transformation in ophthalmology. Here we will explore about what artificial intelligence means for practicing ophthalmologists, its promise and limitation, and what the future holds for it. So as my following speakers will discuss about the various roles of AI in their respective specialties. I'll just give a brief introduction. It is used in the retina. First of all, it's very promising results it is showing in the retina through to accurately detect the diseases, diabetic retinopathy and diabetic macular edema through fundus photographs, and even it is used for first AI-based tools for the retina is actually US FDA approved as IDX DR device, which is already in use since April 2018, and like the details of which will be explained by the co-speakers. And AI is also used in the retinopathy of prematurity as well as in ARMD. So, and analysis of corneal topography is also we can predict, but the good results have only work which has got good results done with the retina structures. But
hello,
yeah,
no,
okay, and the other will be followed by my co-speakers. Okay, thank you.
Thank you, Dr. Aditya, for briefing and giving an overview of what artificial intelligence is going to do in ophthalmology. And then the most important aspect is the machine learning. That is the basic aspect, the background with which the entire artificial intelligence is going to be implemented in ophthalmology, I suppose.
Our next speaker is Dr. Abhishek Anand. He will be presenting on artificial intelligence and diabetic retinopathy. Currently, he is working as an assistant professor in the Vitro Retina unit of Regional Institute of Ophthalmology, IGMS Patna. He has awarded with the A.K. Prasad Gold Medal, AIOC2010 Best Paper Award, and multiple travel grants and co-researchers in ongoing national and international clinical trials. 11 publications in the pre-review index journals, and he presented his work in various national and international conferences. Now, Dr. Abhishek, just start your presentation.
On the outset, I would like to thank J. Jagwal sir for making me a part of this very extraordinary and very exciting topic, which is going to in the whole world of medical medicine. I think ophthalmology is one of the part which is going to be first influenced by AI, because it's very picture-based analysis of the disease. And thank you for Aditya, my previous speaker, for elucidating a very complex topic in a very simple manner. Thank you. So I would not go. My talk will not involve very much into how AI works, but basically how AI and DR can work synonymously and help a very potential problem which is going to rattle the world. We all know that the incidence and prevalence of diabetes mellitus is increasing, and India is going to be the world's diabetes capital. There is almost 123% jump in cases between 1990 and 2013. And as this sedentary lifestyle is more and more cropping in, and we have the effect of COVID, and more digital life is going on, diabetes is going to increase. So screening for DR is a must, and they are currently established models, and they are mainly focused on human grading system. Now, what is the problem with human grading system is that it's a labor intensive. It requires trained human graders. So you have to validate the graders who are there, who should be trained, and they should also have a regular quality assurance and be retained. And plus, you also have to retain the manpower. Scalability is a major issue, and the high cost of human manpower and fixed working hours. If we apply just the UK current annual screening protocol to India, let's just translate it to India, globally we would require almost 2.2 billion retinal images to be graded in 2030. So that is a huge number. And this is where AI comes. In the last decade, large strides have already been made. There are a lot of algorithms which are already there, and there are a lot of big companies which are already working on it. In developing automated retinal analysis system, some designed specifically to detect DR. These rely on different image analysis methods, generally based either on human decision-based algorithms, or what is the new is the machine learning, or self-teaching, or what we have called is the plasticity of the model, a mixture of these two broad approaches. What is the difference between an automated ML or deep learning based algorithm versus a human based screening is that they do not get tired and can grade thousands of images a day and are often able to provide results within seconds to minutes of taking the photos. And I was just, after last 2 weeks back, we were informed that we have a small hospital which is an endocrinology hospital in Patna, Gadinger Hospital, and there is a machine which has been installed. It is just 18 lakhs. And it has inbuilt AI with almost 95% sensitivity and specificity developed by IIT Madras. And they have got it installed. And we are trying to collaborate. RIO is going to collaborate with Gadinger Hospital at scaling automated DR screening programs are furthermore largely just a matter of acquiring more hardware, and they are non-human resource development. Diagnosis of diabetic retinopathy is only contingent on the use of a single modality image. So that is the advantage. What is important right now is whether we want to do a mid-Adriatic or non-mid-Adriatic imaging and the field of vision. But with the new machines that we have coming up, I think non-mid-Adriatic wide finger fundus imaging is now a reality. Almost 60 degrees of view you can have in a non-mid-Adriatic fundus also. So that is one of the very advantages. And this is determined by classic, and second is it has very classic morphological features in the retina, that is microneedles, hard exudates, without the need of additional clinical data and input. So making a diabetic retinopathy screening highly amenable to teleophthalmology, which is already there at multiple centers, as a digital service to decentralized care. So here the artificial intelligence and teleophthalmology for diabetics is what is, there is already multiple centers who are already established their teleophthalmology model. So what we need to do is that we can synergize the artificial intelligence with the already established teleophthalmology model. There can be a synergy between these two digital innovations, that is the telemedicine, which is almost, I think from last 15 years it has been working, and artificial intelligence for diabetic retinopathy screening. And that is already being incorporated in Arvind and many other centers like Sankara Nethralaya. And there is a clear public healthcare need for diabetic retinopathy screening that cannot be met with current models. And we should see AI as an incremental technology. With foundation in teleophthalmology, artificial intelligence solutions are easier to incorporate in the diabetic retinopathy screening problem. Artificial intelligence should be considered as an add-on or incremental rather than an entirely disruptive technology. So we should stop, there is a fear mongering among a lot of that it's going to disrupt the whole thing. So we should take it as an incremental model. Existing shortages in the required resources to cater to the growing burden of diabetes mellitus, as we have emphasized once more every time, create the clear need to implement AI. What is important, if you have the core concept of DR telescreen, there is a clearly defined public health gap. They use a single modality fundus image with standard camera and IT infrastructure, and diagnosis of DR requires no additional patient or clinical data. Robust outcome and cost-effective studies are already there, and there is impact of change that is primary care provider none for the ophthalmologist. So when you merge these two, so we can have a lot of the impact that we will translate on the ground level is going to be huge. And AI can be implemented at multiple levels. So it can be implemented at the screening level. It can, after you have done the core analysis of screening, the main burden is done, then you can do for a DR prediction model. And third is, how do you predict the treatment response based on AI? It can be a predictor, it can be a screener, as well as, there are multiple levels where you can incorporate AI. There are a number of systems for automatic detection of DR are already available commercially, and there are a lot of which are already open source. So you can just go and it is available in the public domain also. With others in the pipeline are still in the early development. Nevertheless, regardless of developmental phase, most of these systems are still being actively developed with changes and improvements to detect for detection algorithm, user interface, scalability, and better detection of diabetic macular edema. So as was already discussed, Aditya has said that in 2018, FDA has already approved an AI-based system for use for DR screening. So it's already there, it's present, and it is being used. An adequate balance between a high sensitivity and a specificity is the key to establishing cost-effective screening programs. So if you have with lower sensitivity, more cases of DR will be missed, which goes against the main aim of a DR screening program. So we have to have a system which has a high sensitivity as well as a high specificity. Because if you miss the specificity, a relatively large number of false positives that warrant further examination are returned, which wastes the resources that automated DR screening is trying to spare. With the addition of the new deep learning system, offers the promise of impressively high sensitivity and specificity. So there are 3 tables like this, and these are the models which are already working. And if you look, the first model that was in 2015, and it had a sensitivity and specificity of 91.3%. And the number of images that were taken is almost 10,000 to 1,25,000. So almost 1,50,000 each of the system that requires. And India is also there, BOSS. It came in 2017. And most of them, the sensitivity and specificity is around 94 to 95%, which is pretty good. Now, what is important is there comes with, data acquisition, there is a lot of issues which also cross with this data. The large set of retinal images on which to train and validate these algorithms is the biggest hurdle to development of an AI system. Plus, with the new era, we have also the role of confidentiality. Can we just go and acquire an image and give it to the ML program? Is the patient informed? There is also an issue of data protection. And then India is a very highly unregulated country, but it's not going to be like this forever. We'll have to face the country-specific regulations. And image data set need to be human-graded and leveled as a reference standard. And there is a publicly available Macedor2 dataset containing over 1,700 labeled retinal images has been used to validate and compare some of them. However, what are the cons is that these data sets contain images of excellent quality of a level that is not representative of real life scenario. And developing a DL system against human grading as a gold standard limits the potential effectiveness of the system itself, because you are, the benchmark is already set that it's the human grading versus this. So you have to remove that benchmark and allow the machine to self-learn. Just to skip this slide, this has already been done very well by Aditya. Just to focus on this slide itself, that Aditya already explained what is deep learning, how it works, what are CNNs, what are neural networks. Human ophthalmologists can only take a guess after taking this photograph that there is a 50-50 chance of getting it right or wrong. And Google's IAI, however, can predict it very well, that whether it is a male fundus or a female fundus. And how it is doing it is about, it's deep learning itself. And this, when you allow the machine to work on itself, you'll get new data points. Why this patient is responding to anti-VEGF, why this patient is not responding to anti-VEGF, which patient is more predictive of getting a response, which patient is in the future can develop a high-risk PDR very fast. There are multiple variables which a human mind has its own limitations. And there is nothing more important than AI, which was there, and COVID-19 just exposed it, how much it is required to have a robust telescreening program. I mean, I am practicing in a government setup, and there are patients who are coming me after 1 year, 2 years with very advanced high-risk PDR, with very bad TRD, and they are one-night patients. If we had a robust telescreening program already set up in state of Bihar, might be, we could have, just warned them that you come, take the risk, just come to us. There is an economic consideration to AI also. And in the long term, it will be very beneficial if you see how much patient lives we impact and how much money, in disability we can save. And plus also just for the need, if you physically screen the patients versus an AI-based system. Obviously, there are barriers to AI adoption. The initial input cost is very high. Then we need to have trained technical manpower to operate as well as maintain the equipments. Then we need secretarial staffs. And current commercially available systems require trained human grader verification, especially with the relatively low specificity of most systems. Is AI a concern for ophthalmologists? Well, first of all, unlikely that we'll see a wholly automated DR screening, and it is mainly for screening, and it is not for, right now, it is not advising for treatment. So it's unlikely that in our lab, in our next 10, 20 years, we are going to have a fully automatic system, which is itself diagnoses, predicts, and gives the treatment. So it will mainly include, add on the patient pool that you already have. So it is going to help you only. Human graders will still be needed to judge atypical or low quality images, as well as for a quality monitoring. Increased detection of patients requiring tertiary care will increment only our practice. And deep learning can demystify many concerns in risk stratification and DR management. With this, I will end my presentation. Together we can rise.
Thank you, Abhishek. It is very nice presentation. Just I want to add that, yes, initial cost is more only for the fundus pictures. Yeah. Acquisition of fundus picture. But after that, we have at present in Indian scenario, there are many software who are very less costly.
Because now what happens is that I was just discussing with my brother. He's also working on it. So what they said that now, after you have already validated the images and you have come out with the output, this whole thing you can incorporate in a chip. Chip-based AI is now coming, and it is a new game changer.
So it is very less costly. I think it is less than 10,000.
So chip-based AI is the new game changer.
Yes. Many Bangalore-based company has come up with new software.
Yeah, and the best example that you gave, that with deep learning, the computer can find out whether it is a female, fundus or a male fundus, which as clinician will not be able to do that.
I was just
that is really
I was just browsing through some paper, and few days back there was an AI which has already developed this low-level conscience.
Yes, yes.
That is also something very.
So in the coming years,
Yeah,
it is going to be revolutionize the whole scenario.
I mean, it is just that whether we like it, we dislike it, we have our own opinions,
We have
but
to
we
accept it.
have to accept
It is going to stay and it is going to benefit the doctors as well as the patients.
I just want to add, artificial intelligence is always going to increase your footfall in your clinics, in your hospital, because patient will get something, let us suppose he got diagnosed.
So
Exactly.
He will get treatment, he wants.
Sir, actually, the issue is not that. The issue is right now is that we are persons. AI is stigmatized.
I mean, that what Dr. Sudhir, I mean, that is a validated fact that for glaucoma, I can take an example that 90% of the people are undiagnosed in the villages and all, in the rural population. So that 90% that can be screened, the volume is going to increase.
They get diagnosed by themselves, by artificial intelligence.
They will come back.
So that is the stigma that once we have an AI system, so MNCs and big corporates can install their systems and they can bypass the local ophthalmologists. That is an issue that we have to take care. That how we can work in a synergy and not be a part of a big.
That is the problem. But after all, the human brain is.
Yeah, but then it will be centralized. Because centralized system will control. Yeah.
Yes. Now, our next presenter is Dr. Devesh Kumawat. He will discuss in other retinal diseases like ROP, ARMD, and artificial intelligence. He is MBBS MD from AIMS, DNB, AIOC, FAICO, FRCS ophthalmology in both parts. Senior residency in RPC AIMS, Delhi. Now is ex-assistant professor is AIMS Rishikesh, assistant professor of LHMC, and has with him with index publication of 70. Now, thank you. Now start with your presentation, Dr. Kumawat.
Excuse me, it's not getting displayed.
सब चलेगा क्या?
Excuse me, it's not getting displayed.
चला जाता है क्यों भाई?
Thank you. Good afternoon, everyone. Thank you, sir, for the introduction. So, the previous two speakers have elaborately discussed the fundamentals of AI and the role of AI in retinal diseases such as diabetic retinopathy. I'll be taking it forward and we'll see how AI is helping us in diagnosis and management of ROP and ARMD. So the conventional approach, as we are discussing the conventional approach versus AI approach to treatment and management. So the conventional approach to ROP treatment or management is screening of at-risk infants by trained ophthalmologists as per schedule and then treating once a treatable ROP develops. So the as per the Government of India guidelines, if we follow those guidelines, there are 2 lakh preterm infants born every year who need to be screened. So that's a huge number. And the number of trained ophthalmologists to screen those 2 lakh new infants every year is only 215 as per the Indian ROP Society registration data. So only 215 ROP ophthalmologists who are trained in screening and management of ROP are there. So it's only 1% of the total ophthalmologists in the country, and you can see the huge unmet need which is there. And it's not a one-time job. You have to screen every 1 or 2 weeks till the vascularization of the retina is complete or the ROP regresses. So it's not a one-time job. Multiple screenings have to be done for those many infants by a limited number of trained ophthalmologists. So, and coming to the treatment type, type 1 ROP needs treatment and the type 2 ROP needs watchful observation. And in type 1 ROP, we have zone 1 disease with plus and zone 2 disease with stage 2 or 3 with plus. Another important obstacle that comes here is the inter and intra-observer variability. So to some, this image, some will categorize as a zone 1 disease. To me, I'll categorize it as zone 2 posterior disease. So there is a variability which is there. And even a single person may categorize it as zone 1 or zone 2 posterior disease, depending upon the field of view, depending on the quality of the image. So there is a huge variability. Again, it is also difficult sometimes to correctly pinpoint whether it is zone 2 posterior disease or zone 2 anterior disease. Based on a single image, it may be difficult. And this has treatment implications, because if there is a zone 2 posterior disease, then you may want to give anti-VEGF injection in those eyes, and if it is zone 2 anterior disease, then you may want to do laser in those eyes. And finally, you can always confuse between stage 2 and stage 3. And this also has practical implications, because stage 3 in zone 2 with plus will need laser therapy or anti-VEGF therapy, while stage 2 will need close observation. More subjective is the grading of plus disease in ROP. So earlier there was a 3-level grading that was suggested by IC208, that is no plus, pre-plus or plus disease. But now IC208 has come up with a more subjective continuum of spectrum, that is from 1 to 6, and it is from no plus to mild pre-plus to pre-plus to mild plus. So it has, the grading of plus disease has become more subjective. And if you are not having such photographs with you in the clinics, you may end up reporting it sometime as a mild plus or sometime as a plus disease. So the subjective variability is going to increase if you are using the IC208 classification. So how is AI helping in today's scenario in ROP? It is helping in the following domains: in detection of ROP, monitoring of the disease, and risk prediction. So how AI works, we already know. Dr. Aditya has already told. So with the database of images, fundus images, first a pre-processing is done. In case of ROP, it's the segmentation of the vessels which is done, and then features such as vessel diameter or the vessel tortuosity or the vessel length, and then the area of vascularization, area which is not vascularized, and ridge tissue. These are the features that are looked, and then based on these features the disease is classified, and you get the final outcome whether it's a treatable ROP or non-treatable ROP. So the traditional machine learning tools, such as there are certain tools which uses traditional machine learning, in which humans have to manually tell the machine that these are the features that you have to look, and based on those features the machine tells whether it is treatable or non-treatable ROP or what is the diagnosis. That is the traditional machine learning. So there are certain tools such as ROP tool or RISA and vessel map, but now the traditional machine learning has been slowly replaced by the deep learning or the convolutional neural network based approach, in which it will directly go from the step 1 to step 4 without humans telling the machine that these features are to be looked at. Such an example of a deep learning algorithm which is used in ROP is IROPDL, and it has been granted a breakthrough status by FDA in 2019, and it has been developed with funding from the National Institute of Health, and this has been used in multiple number of studies in the recent past, and this algorithm has a sensitivity and specificity of around 93 to 94%. So it is comparable to the human experts. Now, AI can also be used to monitor the disease progression and regression. So these algorithms, they come to a severity score. So a severity score can be calculated based on the analysis of the image, and that severity score can be later used to see whether the score is increasing or decreasing on follow-up. So that score can also help in picking up early recurrences of disease after treatment or failure of treatment. AI can also be used, it is being used to predict the risk of severe ROP developing in the children. So as early as 32 weeks post-menstrual age, you can use the fundus images, and without having any ROP, the computer will still detect some features, and using the deep learning algorithm, they tell what all babies are at high risk of developing treatment requiring ROP. And this can be predicted a month before developing the treatment requiring ROP. So there is a huge benefit that can be there, because once we know that these are the babies which are going to develop treatment requiring ROP, we can channelize our efforts more toward them. And those babies who are at low risk, we can maybe reduce the follow-up of those babies and maybe observe those babies at 2 or 3 weekly intervals. What are the future prospects? AI is nowadays it is looking at the perinatal management. appropriate management during the perinatal time, so that we can primarily prevent ROP rather than going to the secondary prevention. If we can manage the baby appropriately during the perinatal period, we can primarily prevent ROP. Then, what is the risk of vascular arrest and vascular reactivation following anti-VEGF therapy? That is a huge dilemma these days, that when to treat such babies after anti-VEGF therapy, vascular arrest has occurred or reactivation is occurring in the form of plus or stage. So AI can help us in treating and following and treating those babies more better. And another important scope of AI is in ROP education. So there is a huge variability which is there in the features. So AI can correctly predict the findings, and it can help us teach better, because we ourselves will be more clear that, okay, this is stage 2 rather than stage 3, this is pre-plus rather than plus disease, and so we'll be able to teach better. Coming to ARMD, so the again in ARMD, the conventional approach is that you screen the elderly population which is at risk, and it should be done by a trained retina specialist as per the and then you grade the disease, and as per the grading you treat the disease. If we see the burden of disease in our country alone, there are more than 80 million people who are above the age of 60, and if we see the prevalence data from the population studies, then the prevalence ranges from 1.4 to 30%. So a huge number of population is at risk of irreversible vision loss occurring due to late AMD. So that's why it is important to screen those patients timely and treat them timely. So here comes the role of AI in it, that AI can help us detect the disease in time, classify it, predict the risk of late AMD, and monitor it also. Because we don't have enough trained specialists in our country, we have only 2,000 retina specialists registered in our society. And if we see the population at risk, it will be roughly 20 to 30 million population. So that is a huge load which is there, and AI can definitely help in that. So AI can predict, can detect the ARMD, presence of ARMD, and stratify it based on usage of the fundus images, like we have discussed in ROP, that we can feed the images of no AMD or early AMD or intermediate AMD and late AMD, and then the machine will, through deep learning, come to a conclusion whether there is AMD, or what is the stage, what is the grade of AMD, and what is the risk of late AMD development. Not only the fundus pictures, AI is also nowadays using the OCT images. So based on the OCT images fed, AI can detect whether there is based on the segmentation which the machine does, it can detect drusens, it can detect the volume of the drusens, it can detect the atrophy of the outer retinal layers, the area of the geographic atrophy, presence of CNVM complex. The area of geographic atrophy can also be detected on the fundus autofluorescence images by AI. And even the recent studies have come up with the use of AI in interpretation of OCT angiography images, which till date it is sometimes very difficult to interpret those images, and we are still in the learning phase, and AI may help in better understanding of that software. So AI can also predict the development of late AMD, and the recent studies have told that along with the demographic features and genetic features, we can very well with 95% sensitivity and specificity pinpoint those patients who are going to develop late AMD and focus our efforts on them. AI can also detect the intraretinal and the subretinal fluid automatically, and this can be used for monitoring of the disease. It can pick up early recurrences, and then it can also help us know which patients are likely to respond better to therapy and which patients are unlikely to respond. What are the future prospects? That I've already told that the OCT angiography is nowadays it is being used, images are being used for the AI by the AI algorithms, and newer algorithms are coming up, and they'll help us understand better the OCT angiography images, which currently we are not able to. Sometimes we miss the small vessel network, sometimes we are not able to differentiate between active and nascent CNVMs or scarred CNVMs. So AI will definitely help in understanding that better. AI will also help us to reach a treatment approach to anti-VEGF treatment. There are multiple anti-VEGF treatment options which are available, such as a PRN treatment or treat and extend and monthly treatment. So AI can analyze that data and can provide us with the results that, okay, this is the algorithm which may suit better in your subset of patients. So the challenges with AI are, as already been told, that we need to create a reference standard first, which is when 2 or 3 or maybe more experts, they sit down and then they analyze the images and then they label the images, and then this data is fed into the machine. So there can be an observer variability among the experts as well. So our reference standard itself may be at fault. Then we cannot generalize the results to all the population. Suppose based on the database of Caucasians, we cannot use the same algorithm in the Indian population. If a different camera system has been used, suppose if our algorithm is based on the RETCam machine images, we cannot implement it on the Trinetra Forus images. And if there is a field difference, if we are using a 120-degree field or a 60-degree field, again there will be issues with generalizability. So what can be done about this is we can validate the tool first on the target population and then only use it, rather than directly using it. Another issue is of explainability, because we cannot explain how deep learning is reaching from step 1 to step 4, from image analysis to directly to the conclusion without us telling it that these features have to be looked at. So there comes an issue of trust. So we do not usually trust things which are not explainable. So a way forward is that we can combine the deep learning algorithms with the traditional feature extraction, or that is the traditional machine learning algorithm. They both can be combined, and it has been seen that if you combine both, then your trust improves, your explainability improves, and even your sensitivity specificity improves. Medical legal issues are there, and one has to use an assistive technology first rather than an automatic technology, because even a 5% false negative rate can lead to missing some important cases, such as in ROP, you cannot miss even a single case. And then the issue will come of the blame, that who will take the blame of missing those children, 5% of the children who are mislabeled with AI as well. Financial considerations, there are financial considerations in the initial phase, but in the long run, yes, it may be more cost effective. To summarize, AI-based automatic tools can provide substantial benefits in the diagnosis and management of ROP and ARMD, especially in our country. And till the time we have robust algorithms which get a federation approval, we should use AI as in the assistive mode rather than in the automatic mode. Thank you. Thank you for the patient hearing.
Thank you, Devesh. Your nice presentation. But only thing that whether in future, for ARMD treatment, whether the AI, what I have heard that it will diagnose the case and also give suggestions when to give the anti-VEGF, what will be the course, and when when the anti-VEGF effect is ceased, when the next anti-VEGF treatment should be given. These all are coming in protocol.
Yes, sir. So it is going to help us in making our treatment decisions. So it will tell us when to treat, when not to treat, how to treat, how frequent to treat. So all these will be the norm in the coming future.
Yes, yes.
Thank you. We have the next speaker.
Next speaker is Dr. Pranita Sahai.
Can you upload the presentation, please?
She is not here.
It's a recorded presentation.
Now, Dr. Pranita is going to present on artificial intelligence and keratoconus, ectasia, and other corneal diseases. She is MBBS gold medalist PMCH, MD AIMS, DNB, ICO FRCS. Senior residency in RP Center, AIMS, Delhi, ex-assistant professor, LHM, DEC, Delhi, and ex-assistant professor, UCMS, Delhi, and consultant corneal services in CFS, Delhi. She has, with her index publication, 82. Now, she is not here. She will present her
To
presentation.
present on the topic of artificial intelligence in keratoconus and other corneal diseases. I have no financial disclosures. So as the discussion has been going on, majority of the work in artificial intelligence and ophthalmology is pertaining to retinal diseases. However, the upcoming studies show that artificial intelligence is being explored in areas of corneal diseases, cataract, and glaucoma. In cornea, the most common areas wherein artificial intelligence is being applied to include keratoconus, refractive screening, infectious keratitis, dry eye disease, Fuchs dystrophy, pterygium, and corneal transplantation. Keratoconus and refractive screening are two of the most hot topics and most explored areas for artificial intelligence in cornea. Pentacam and OpScan2 are the two conventional tests that are used for identification of keratoconus. The results of these tests are extremely sensitive and are highly predictable. However, the reports of these tests show a vast data set and require an experienced eye care professional for its analysis. So why is AI important in keratoconus? Form frosty keratoconus identification and keratoconus progression are two most important areas in the field of keratoconus that require early detection with close monitoring and prompt treatment with corneal cross-linking to preserve vision and result in better visual outcomes. However, there's a lot of confusion while assessing the Pentacam or OpScan reports in FFKC identification and assessing serial reports for keratoconus progression. That is where artificial intelligence becomes handy. The data that is pre-fed onto the algorithms of AI for developing softwares for keratoconus identification include refraction, imaging data of keratometry, elevation, tachymetry, heat maps, and also ocular biomechanics. The various algorithms that are used are described in this table. The most common ones are the convolutional neural networks and random forests that are used in keratoconus identification. The Pentacam images are most commonly fed onto these algorithms, and ultimately these algorithms are able to identify normal versus early keratoconus and advanced keratoconus. So keratoconus identification, staging, and progression all can be done with the help of artificial intelligence. Also, prediction of visual and refractive outcomes of treatment like intracorneal ring segments has also been described with artificial intelligence. Overall, a high sensitivity and specificity has been reported for keratoconus detection with AI. Also, some studies have compared AI with non-AI indices, that is the KISA and the keratoconus index, and reported similar outcomes between the two. Keratoscreen model is one of the models that has been developed to screen early keratoconus and other ectasias using Zernick polynomial data from the corneal topography and tomography. It uses an artificial neural network. KeyDoc, that is the keratoconus early detection and of progression model, uses serial Pentacam reports with a deep learning neural network algorithm for detecting keratoconus progression. Manual detection of progression versus image-based detection of progression was compared in this study by Reddy et al., who found that identification of progression was earlier and CTVA was more stable in AI-based detection of keratoconus progression and interventions. An ongoing project which is being developed is the smartphone-based keratograph for identification of keratoconus. So this is like a cost-effective alternative to the expensive equipments of Pentacam and OpScan, wherein the smartphone has been coupled with a Placido disc-based imaging, and the software is extremely user-friendly and does not require a healthcare professional for capturing images or analyzing the results. Hence, can be used for community-based surveys or screening for keratoconus. Keratoconus severity classification has also been studied by various authors using artificial intelligence. Refractive surgery is one of the most common procedures performed in ophthalmology after cataract these days. And with innumerable patients turning up for refractive surgery, it is very essential to screen these patients well to avoid long-term complications. So AI in refractive surgery helps in prognosticating visual outcome and also calculating the risk of post-LASIK ectasia, which is extremely pertinent in these cases. Pentacam random forest index is one of the parameters that has been developed with artificial intelligence, which when compared with BAD, that is the Bell&Ambrosio display, that is the conventional test for identifying risk of post-LASIK ectasia, it was found that PRFI was way better than BAD in predicting post-LASIK ectasia. Also, machine learning model was compared with conventional methods of person tissue ablation and Randleman ectasia risk scoring, and it was found that the machine learning model was better. It was correctly able to reclassify patients of post-LASIK ectasia as ectasia risk group on the basis of pre-operative data that was available and fed into these algorithms. Now, AI has also been explored in infectious keratitis, where these algorithms have been correctly been able to identify corneal ulcer and also the type of corneal ulcer. It was observed that the diagnosis with these AI-based algorithms was found to be better when compared to clinicians. Also, the specificity of these algorithms for fungal keratitis was way higher when compared to bacterial corneal ulcers. It not only identifies corneal ulcers but also assess the disease severity based on the measurement and assessment of size of the corneal ulcer. And because it is able to assess the size of the corneal ulcer, it can also assess the response to therapy, medical therapy that is being given to patients by assessing the serial clinical photograph results. Now, this is a study by Patel et al. Where they reported the measurement or assessment of size of the corneal ulcer with artificial intelligence. You can see that the ulcer was monitored serially serially with artificial intelligence. And in fungal keratitis, it has also been put to use for assessment of results of confocal microscopy. As you're aware, the confocal microscopy results are provided in multiple section images, and each image needs to be analyzed closely to give appropriate and good results. An automatic detection of these sections, especially when detecting hyphae in cases of fungal keratitis, can be extremely time saving and can reduce the workload of the healthcare workers. Now, various other corneal pathologies where AI is being explored are dry eye disease, wherein ASOCT images have been used to assess the thickness of the tear film. Frontal eye videos have been used to assess the tear breakup time. Tear film lipid layer interference images have been used to assess the lipid layer breakup patterns to compare to assess and diagnose evaporative dry eye when compared to aqueous deficient dry eye. In Fuchs dystrophy, deep learning algorithms have been used to identify early Fuchs dystrophy where there is only descemet endothelium complex thickening without any evidence of corneal edema. In pterygium, AI has been used to identify pterygium, its location, and also its size. Pterygium net is one of the algorithms that has been put to use for this assessment of pterygium. Some authors have also reported use of AI in assessing post-DMEC graft detachment, wherein the artificial intelligence algorithm automatically assesses the ASOCT images and identifies even minor or shallow detachments of the DMEC graft. So these are the areas where AI has been used in corneal diseases. However, the major limitation is that there are different algorithms and softwares for assessment of each of these diseases. A single software that can assess multiple diseases altogether and in the same software is something which can be most beneficial to the clinicians. A similar software was developed by Elsevier et al., where a single image of ASOCT was assessed by these deep learning neural network algorithms and identified dry eye disease, Fuchs dystrophy, and keratoconus all three with the help of single AIOCT image. So development and refinement of such softwares in future is something which will be most promising for clinicians to use in daily practice. Thank you.
A good presentation by Dr. Pranita. Now she is not here, so
Good afternoon,
I don't think.
everyone. Myself, Dr. Pranita Sahal, and at the outset, I would like to thank.
Now our next presenter is Dr. Pranav Ranjan. He will be presenting on the current landscape of artificial intelligence for detecting glaucoma management and its progression. He is the Vice President of ISOC and the President of
Good afternoon, everyone. And
President of AIOC2022.
this is an absolutely new topic for me. I have been preparing and understanding myself as to what artificial intelligence is going to do. And the topic that was allotted to me was glaucoma. Iska full screen kar dijiye na? Can you do the full screen? The role of artificial intelligence in glaucoma. And this is the global prevalence of open angle glaucoma, which is close to 54 million. Second. Worldwide, the open angle. $53 million to be precise, the open angle glaucoma. And the overall glaucoma which has been detected is approximately to the range of 80 million. These are the tools which are basically required to make a diagnosis of glaucoma. And you see in the center is the fundus imaging device, the fundus camera, which has been of lot of interest in artificial intelligence. And this is the neural pathway that the optic nerve, the optic chiasma, and the entire eye basically covers the entire brain parenchyma. Overview, we have already seen the two important aspects in which the artificial intelligence is going to be applied is diabetic retinopathy, glaucoma, AMD, and ROP. These are the things. Prelude that glaucoma, early glaucoma is typically asymptomatic, and this is one place where artificial intelligence can tell you how to predict glaucoma at a very early stage. And with more patient and less chair time and the volume, we have to ensure that nothing is overlooked, and for that, this artificial intelligence, without taking much time, can give you as to what the patient is going on, how the patient is going to behave. What I just said, that approximately with about 90% of the rural population and 50% of the urban population remaining undiagnosed as far as glaucoma is concerned, here the role of artificial intelligence is going to come handy. What is the role of artificial intelligence? As in other diseases, screening, early detection, diagnosis, classification of glaucoma, quantifying risk factors, progression, through an automated processing of large pool of data. Why this is important in glaucoma and why this becomes relevant? Because there's a lot of data in glaucoma investigation, whether it is perimetry, whether it is OCT finding, whether it is the fundus camera finding. So a lot of data is there. So all the data if they are collected and each of them are interlinked with each other, the prediction and the diagnosis becomes easy, and that can be done by the deep learning of the machine. The basic definition has already been covered. The most important is the machine learning and the deep learning. The deep learning basically is the interpolation of all the data from various sources so that you come to a definite conclusion, come to a definite diagnosis. IOP is one thing which has not been very much understood by artificial intelligence, but still it holds true to the fact that something can be done for it. One study which used triggerfish, it is a contact lens based continuous IOP monitoring system, and with this continuous IOP monitoring system for 24 hours can give you a lot of data, and this data can be interpolated with the kind of fluctuation and the kind of progression that the glaucoma can have can become relevant, and artificial intelligence can play a good role here. This is one aspect which has been thoroughly and intensively and extensively studied is the optic disc photograph, and a lot of research and a lot of algorithms have come in from various sources, which shows a high sensitivity and specificity almost to the range of 95% and 92%. A lot of work is being done here. And how it works, basic understanding, I also try to understand this. It is a pooling of all the fundus data. And this data by an expert is defined into two categories, categorized like whether it is glaucomatous and non-glaucomatous. And based on that, it is fed into the machine. Now the machine develops an algorithm, and these algorithms can have actually a better result than the human examiner. And the photograph in the bottom shows that you you take a fundus photograph that is taken to the machine, the image is convolved, it is pooled, then it is processed, and finally you get an output, whether it is a definite glaucoma or a non-glaucomatous. And that is a set of deep learning by which it is arrived at. When we look at any fundus picture, a human looks at a fundus picture, he sees the picture in black and in colored this thing. But when a machine looks at a picture, it looks at into it with numbers, various numbers it gives. So every image that is captured is given a number, and that number is fed into the machine, that is stored in the machine, and whenever a new, and then that is branded whether it is glaucomatous or non-glaucomatous, what is the CD ratio, what is the NRR, etc., etc. The various parameters are all fed into it. And whenever a new photograph, fundus photograph is fed into the machine, it compares with the previously loaded data and gives you a final outcome. These are the various imaging algorithms that have been carried out, like the Khalf Innovations from India released retinal image analysis glaucoma cloud-based software in 2016 to analyze fundus images. It uses an advanced image processing algorithm to measure the optic disc, cup size, CD ratio, NRR thickness, disc damage, likelihood score, and to look for violation of isn't rule. It also uses deep learning to learn from the user in case of errors in automated detection. Another field is the optical coherence tomography, the OCT. The OCT automatically measures the disc, the cupping, the NRR, the retinal nerve fiber thickness, the glaucoma, the GCL thickness. By Singh et al., the artificial intelligence image processing technique is known as segmentation. Muhammad et al. Have showed that a hybrid deep learning method on a single wide field swept source OCT has a 93.1% sensitivity in detecting glaucoma suspects. Ashoka et al. Evaluated a deep learning algorithm with a pre-training that diagnosed glaucoma based on macular OCT, and that was a replacement for RNFL and GCL. Artificial intelligence also can come handy for anterior segment OCT, and it can classify by segmentation of structures whether the angle is going to be of what kind, whether it is going to go into an angle closure or not. So this is also one thing which is going to be very, very helpful. Visual field is one thing which has really taken the artificial intelligence in a big way, and it can help in rapid and accurate interpretation of visual fields. Ashoka et al. Used a feed-forward neural network to identify pre-parametric visual fields which did not meet Anderson's criteria. Lee et al. Evaluated a convolution neural network to automatically differentiate between glaucoma and non-glaucoma visual field. Anderson et al., they have trained the artificial neural network to obtain 93% sensitivity and 91% specificity in evaluating glaucoma visual field, and it performed as well as the clinicians. Bod et al. Has successfully analyzed the FDT perimetry data. So this is the visual field that we see the printout. These fields do not quantify the nature of regional loss, and the summary indices in the form of mean deviation and the PSD, they are limited to overview only. So we need to get more information on the visual field, and this more information, this was studied in the archive type of analysis done by Tobias Elzy from Howard University, in which the regional defects were given were segmented and given a linear equation so that we can find out that from the top, this defect is basically 43.3% in this area of the normal. This defect here is 33.6% of the normal, and the other one is 22.6%. So all the areas in the visual field, they are given a different probability whether how much of normal they are. And based on that, 2 decades of study, almost 20 years, 2045 retrospective fields were analyzed, and in which the 5 scientists, the doctors, they worked on and they found that there are 14 patterns of visual field that can be assessed and that can be detected. And based on that, this visual field was the one which was giving a lot of interest. This created a lot of interest, and this is the central area which is getting affected first. So what they said, and especially in the normotensive glaucoma, the interest was there that instead of a peripheral loss, there is one pattern in which the central loss is there. So this also has to be kept in mind that glaucoma is not only a disease which affects the periphery, it can start from the perimacular area also. The combined approach, it combined the non-ophthalmic factors and the ophthalmic factors. The non-ophthalmic factors that were combined were sex, age, menopause, duration of hypertension, and 5 ophthalmic factors: the intraocular pressure, the refractive error, vertical CD ratio, presence of superior temporal and inferior temporal RNN defect. These five parameters, and altogether the 9 parameters, they were interpolated with each other, and it was found that even without a visual field, they can predict glaucoma diagnosis, they can diagnose glaucoma, and they can predict the progression as well. So predicting prognosis, the various machine learning defects the visual field progression consistently, even with slow progressors. It works on a portable perimetry device like the screener, etc. When Lee and colleagues trained a deep learning system with almost 32,000 visual fields taken between 98 and 18, and it was found that this can predict a visual field progression even before 5.5 years. Carlsman et al. Developed a validated Kalman filters which could predict progression of mean deviation of visual field at different targets of intraocular pressure. This would be helpful guide to customize and target the intraocular pressure. The future prospects, the algorithms are always getting better. The near future we can expect to have an AI that has extremely good sensitivity and specificity, and it can surpass the human ophthalmologist. Combine various glaucoma evaluation can achieve a perfect diagnosis and prognosis. But the most convenient would be if a single test can be extrapolated using an artificial intelligence to predict the other. For example, if a single OCT can predict the visual field using an AI for extrapolation. The 6 pearls: try to make the best diagnosis, assess all major glaucoma risk factors, use all tools at your disposal. Do not underestimate life expectancy, do not assume that glaucoma damage will only be peripheral, and do not miss a good opportunity for screening. And for screening, not only do the human screening, but also take the help of artificial intelligence. So with this, I come to the end of the presentation. Thank you so much, and I thank Dr. J.G. Agarwal for giving me an opportunity to speak on the topic.
Thank you, Dr. Pranav. Just I want to ask one question. How community will be benefited in the mass level screening to evaluate or
the data which I showed, that almost 90% of the population in the rural area, they are still undiagnosed, and 50%, almost 50% of the rural population are undiagnosed as far as glaucoma is concerned. So that 90%, if they can have the fundus picture, if they can send the fundus picture, that would be a great benefit, because sitting here 200 or 300 miles away from the villages also, so we can get a close assessment of the fact whether it can be glaucoma or not, and based on that, those patients can be called. So that's a very convenient way of diagnosing things.
You have mentioned that software for 2016, but 2020 has, another software has come, most probably from Bangalore. remedy?
While going through the literature, what I found basically that if one tool can interpolate the other tool, like OCT picture can take into account the fields also, predict the field also, that would be a great advantage, because multiple examinations, instead of doing a multiple examination to arrive at a diagnosis, it's always better at the level of screening that you do one screening test and you come to a almost conclusion that this is what.
No, during screening, first will be the fundus picture.
Fundus picture is the most important. Fundus picture is the most important.
To whether the patient further go for OCT
Absolutely. One thing I learned from the literatures is that the fundus picture, there are two aspects to it, right? One is the machine learning. By taking a fundus picture, the machine learns only the outlines, basically. Only the outlines. It will give what is the diameter of the disc, what is the diameter of the cup. Whereas in deep learning, there are other factors also, like the contrast, the vessels, the slope, the elevation, everything is taken into account. So through deep learning, it becomes a complex process and we are able to understand the mechanism more precisely. And if those data for 10 years or 20 years, they get validated, then we are pretty close to coming to an accurate diagnosis.
Do you know any software which analyzed all three steps? That is,
I think you know better than me, because you have been doing this workshop for a pretty long time. Can you tell us, is there any software?
Actually, I don't know that it is at present in India, but outside there are lots of software. There.
So the software are going to come, they are going to develop, and they are going to become more robust. Robust in the sense, you can really depend on them.
Oh,
yeah, even if you are not a glaucoma specialist, even if you are not a ROP specialist or a diabetic specialist, at least you will be able to arrive at a diagnosis and send the patient with a proper referral.
Okay, thank you, Dr. Pranab. Now, next presenter is Dr. Gyan Bhaskar. He is presenting on oculoplasty management and role of artificial intelligence. He is the professor and head unit 2 of RIO Indira Gandhi Institute of Medical Sciences, Patna, and he is secretary of Patna Ophthalmic Society, and he is a PG examination of different university, and he is awarded gold medal by the Bihar Ophthalmic Society. He has various publications in PubMed and index journals and presented national, international, and state-wise conference. Now, Dr. Gyan Bhaskar, please go through your presentation.
Thank you. Thank you so much, sir. Good evening, everyone. Now I'm going to discuss about the oculoplastic management and role of artificial intelligence. For the diagnosis and proper management of oculoplastic cases, we are totally dependent upon the clinical evaluation. And for that, we require highly skilled and experienced surgeon. Even there are chances of human error, and not every case could be handled with perfection. Moreover, in our country, there are large number of patients concerning the same, but in contrast, a relatively lesser number of expert ophthalmologists and expertise center are present. So the role come the need of development of artificial intelligence that would enable proper diagnosis, evaluation of the disease, and it would be beneficial for both patient and the general ophthalmologist. Allowing the former and access to perfection and later an opportunity to achieving early diagnosis and proper management. In cases of oculoplastic surgery, it is a specialized eye treatment. It includes the eyelids, eyebrow, orbit, tear ducts, and sometimes faces. And oculoplastic surgery ranging from the improving to the treatment of the dropping of the eyelid to the replacement of the eye. Based on the research and literature available, I will discuss about the blepharoptosis and lid mass and the software that has been developed by the researchers and for their diagnosis and management. In cases of evaluation of the management of ptosis, as you see, there are three photographs, the dropping of the upper eyelid of the child, younger age and older age group. Overall, the past few years, development of artificial intelligence, most notably deep learning, have significantly increased the capability of machine to stimulate human-like perceptual judgment. The AI approaches to facial analysis show promise in clinical evaluation of abnormal lid position. It could allow more neutralistic, qualitative, and automated assessment of the lid position. Some software available like convolutional neural network architecture such as VGG16, ResNet, DenseNet diagnose the true blepharoptosis without any input of eyelid measurement from the clinical photographs. In the photographs, simply photographs can be taken by a handheld camera, any handheld camera, in order to crop a standardized image of a single eye. An open face and open source package was utilized to identify major facial landmarks in each photographs. For the ptosis classification, most of the common models such as VCG, ResNet, AIOC2022, and SqueezeNet and DenseNet were used. All have similar performance, and therefore among those models we can choose the relatively simpler model, that is the VCC16, a computerized resource efficiency model. It is a base model and it is developed by the Oxford Visual Geometry Group. And some gradient weightage class activation map, that is a grand map, is a visual explanation of the AI model which is applicable to wide variety of CN model families. And for the understanding of AI model prediction, a heat map can be used to identify the area of input image that contribute most of the AI model classification using a technique called class activation map. These photographs was taken from the net. It is the shows the original photographs with the merged with the grand map photographs, shows the amount of the ptosis, blepharoptosis, and healthy position of the eyelid. Another model, that is a bespoke automated image analysis tool, has been developed for the express purpose of assessing the eyelid position. Generally, we measure the eyelid with the scales or ruler for regarding the ptosis evaluation like MRD1, MRD2, pulpitular aperture, levator function. But these tools can analyze these things automatically. And another model is used for assessment of the peripheral measurement, automated measurement of the eyelid. The deep learning semantic segmentation network can be used to fully automated periorbital measurement. Three area of the each photo like eyelid, aperture, iris, eyebrow can be segmented bilaterally, and this segmentation will then be used to train the deep learning semantic segmentation model consisting of Valena PSP net with the ResNet 50 backbone with UNet style of sampling arm. In cases of the eyelid, we know that the benign and malignant eyelid tumors sometimes have overlapping feature, and hence differentiating between them are to be challenging. Just to see here, some photographs from the are taken lower and upper lid. Some are the malignant one, and some are the benign lesion, and it is sometimes very difficult to diagnose clinically without his pathological examination. So literature available recently published artificial intelligence detect malignant eyelid tumor from the photographs, and these work on the difference diagnosis on the based on artificial intelligence for the early diagnosis. And for classic deep learning algorithm like DenseNet Net 121, ResNet 50, Inception V3 and VG16 can be used to train a model to distinguish malignant eyelid tumor from the benign one. And these photographs are also taken from the net on this based on the literature that you see here. The dotted green line are the healthy one, and orange line shows the detected result by the RCNN. And to investigate the interpretability of the system in classifying benign and malignant eyelid tumor, heat map can be created to visualize the region that contributed most of the system decision. The heat map could highlight the region of benign and malignant eyelid tumor, regardless of the size, location, and shape of the tumor. It is also taken from the net of the same study that the original photograph. This is the original program. This is the crop one, and this is the tumor-centered heat map was created so that we can distinguish between the malignant and benign tumor. This is the benign lesion, and also cropped image was centered with the heat map. So conclude that open source artificial intelligence-based facial analysis software will able to perform a good level of agreement and manual human assessment of the pulpy aperture. AI-assisted ptosis diagnosis tool can be the great impact on the management of congenital ptosis, since up to 1/3 of the congenital ptosis patients are at risk of amblyopia. The accurate diagnosis of ptosis based on the external photograph would prove especially helpful in pediatric population, as the eyelid examination can be challenging in uncooperative or crying children, patients with a developmental delay, and babies. And heat map could highlight the region of benign and malignant eyelid tumor regardless of size, location, shape of the tumor, and thus can be helpful treating the eyelid tumor. Thank you so much for your patience hearing.
Thank you, Gyan, for your nice presentation.
Next, just one thing I would like to highlight. I mean, the last line that you said, the differentiation and to differentiate between a malignant and a benign tumor, if that can be done by artificial intelligence, that will be a boon for everybody.
Yes, sir.
We have the next speaker, Dr. Jai Gopal Agarwal. He is the chief instructor of the course, and his topic is IOL power selection using artificial intelligence. He is an ex-principal, School of Optometry and Orthopedics, Aligarh, and ex-deputy Chief Medical Officer, Gandhi Eye Hospital, Aligarh, senior consultant at Kurji Hospital and Agarwal Eye Center and Research, Patna. He is the past president of Patna Ophthalmical Society, vice president of Bihar Ophthalmical Society, has several awards and presentations in state, national and international conferences. So it's over to you, the chief instructor, Dr. Jai Gopal Agarwal. And this is going to be a very interesting topic. I hope all of us will learn a lot as to what kind of IOL and what IOL is going to be the best for that particular patient. And that particular patient may be a VIP or a poor, but...
Good afternoon to everybody. My topic is IOL power selection using artificial intelligence. Here I will compare with the previous formulas, decision formulas, and recent artificial intelligence-based formulas. The purpose of this IC is to compare the accuracy of widely used IOL power calculation formula, including the artificial intelligence-based formula, namely Hill RBF, LEDAS formula, and very popularly now discussed nowadays, Keynes formula. Regression formula we all know, SRKT, Holiday 1, Hopper Q, Haigis, Barrett's, Oleson, and EVO. I have just new formulas I have only taken for comparison. Now to calculate the IOL power, we have improved expensive machines, multiple formula of different situation, so we have many pearls. Even then, the results are not perfect in the regression formulas. They all require input data, regression-based calculation method, and have problems of ELP, which is still a challenging issue. No human can ever write a single formula that can take account every adjustment and variables. That's why for biometry, till now, we have used decision trees to decide which formula we should use for a particular case, that is cumbersome intuition and leads not a lot of experiences in regression type of formula. This intuition is mainly due to inaccurate calculation of expected lens position. But how can we convert this intuition into the approach that is easily available and useful to even the less experienced surgeons? Now, how to be close to the perfect IOL power calculation? Now, we have recession formulas like Barrett. No doubt it is very good. It is based on theoretical model. Consider the change in the principal planes among the variety of IOLs by means of lens formula. Estimate the ELP, that is very important. Estimate of ELP based on the anterior chamber lens depth and lens factor relation and actual position and the location of the principal plane of different power IOLs. Utilizes 5 variables that you all know. The Barrett 2 is addressed different IOL shapes and offers adjustment required for the low and negative power IOLs. Now, next is the Oleson formula. This is a new concept of the ray tracing assisted intraocular power calculation. It is the key feature of Oleson formula is the accurate estimation of IOL physical position using the newly developed concept of C constant calculated directly in the formula. C constant is the ratio of the preoperative thickness of the crystalline lens by which the IOL will locate itself following the bag implant. It also eliminates the ELP, so it is better than other regression formula and uses only K, axial length and wide to wide. So there is no more guess like expected lens position, so it is better than others. EVO formula, that is emmetropia verifying optical formula. It is developed by Ton Kwa Yo and it is based on the emmetropization and the generation of emmetropia factor for each eyes. Now version 2 has come for long and short eye and also for the toric, and it is also for the post-myopic refractive surgery prediction. So it is very revolutionary formula. It should be used in the pseudophakic IOL during the cataract surgery and not used for the refractive phakic IOL like ICL. Now come to the artificial based calculation. It is more to get more accurate result. We have artificial intelligence based calculation with 2 main approaches. Using the direct artificial intelligence approach by pattern recognition, that is Hill RBF, and using the sweet spots of multiple formulae. Here we create 3D surface from the big data collected from the sweet spot of multiple formulas. On entering the data, the perfect results are obtained by using artificial intelligence pattern recognition within the big data in Ladas super formula developed by John Ladas. Sweet spots are the places where we get the maximum correct response for a given amount of inputs, because for the formula, not all the ranges of input given the results equally maximum correct response. I want to say that for each formula, we cannot get a good best result from every variables. There is such spots in any formula that we get the very good result. That is called the sweet spots. Now, how does artificial intelligence based formula works? When we upload the data of a patient, artificial intelligence based formula finds distinct pattern in the apparently random cloud of data points already created a large amount of cases based on the pattern recognition of artificial intelligence. Thus, it is a purely data-driven IOL power calculation approach, free from the limitation of expected lens position and also free from the limitation of inherent standard formula. And this artificial based formula is adaptive. It is a dynamic learning process and continuously becoming better and better by updating itself, by entering the large number of surgical outcomes into the cloud. Just I have shown that is how it is data is input, and in the hidden layers there are variables. It can be 7 variables, 3 variables, and 4 variables. After the processing, we get the outcome is a very good results. Now Hill RBF formula, it has variables are AL, K, ACD, CCT, WTW, lens thickness, gender, ethnicity. Limitation are inbound, prediction valuable, reliable, and prediction value is high probability, that is plus minus 0.5 of target outcome. Ladas super formula based on the creating Ladas super surfaces. Here is Ladas super surfaces of any formula. In one axis, it is in the Z axis, it is IL power showing the axial length and corneal power in the XY axis. Now, LADA super formula is constructed using the sweet spots of 4 formulas: Hopper Q, Holiday 1 with Van-Koch adjustment, and Haggis. If first figures is sweet spots are each formula are presented in the colored diagram. Now they are all connected, and lastly, LADA super surfaces is created by amalgamation of all threes. Now this is the interface of LADA super formula. As soon as we give the input, we get this type of interface where we can see it is the 3-dimension graph. The surgeon knows instantly if he is handling typical or unusual eyes. Now, if you compare with the Barrett universal formula, that is regression formula, here it says the LADA super formula gives the best possible calculate IOL power in all types of eye, including the extreme eye. Thus, edge over the Barrett's universal formula. These yellow blue areas are they are almost identical results, but in the red areas in the Barrett formula, they are varied from the LADA super formula, where the LADA super formula gives the better results. Now, come to the Keynes formula, which is very common discussion nowadays. It also incorporates the artificial intelligence-based formula. It requires parameter of axial length, K, ACD, gender, and A constant. It accurately measures the all range of axial length, but it is in large cohort study and validation. To verify, I have conducted retrospective studies. I am not going in details, but the data which I have collected from my small hospitals, that is the mean numerical error for Hill RBF and LADA super formula has the mean numerical error is very less. So it is better than other regression formula. In the mean absolute error, which has the basic of any correctness of the formula, here also the Hill RBF and LADA super formula is better. If sensitivity is taken, then the 0.5 diopter ranges is with the LADA super formula and the Hill RBF. So they are all artificial intelligence formula, they are good. So LADA super formula prediction is predicted more eye within the 0.5 diopter with spherical equivalent compared with the other formulas. For extremes eye, again, LADA super formulas and other artificial based formulas are far better because mean arithmetic error is less than other regression formulas. For the toric IOLs, it is for your sake, it is that for Barrett toric calculator, cylindrical part is very good. But if we add the LADA super formula along with the Barrett toric calculator, we get the very good correct power from if you combine LADA super and Barrett toric calculator. For the post-classic calculation, no artificial intelligence-based formula is still present. To conclude, the advantage of artificial intelligence-based formula, it is totally data-driven based on the pattern recognition without estimating the expected lens position. Artificial intelligence-based formula is continuously evolving, thus becoming more and more accurate, accuracy above 90%. LADA super formula is better and a single answer for any IOL power query, not with no outbound limitation as in Hill RBF. It incorporates the sweet spots of many existing formula into a single formula. It is time saving, no need to create calculation tree. Task of IOL power calculation can be delegated to the technician and the website does all the decision making. Ophthalmologists can now totally focus on surgery, leaving the mathematics to the artificial intelligence-based formula. So LADA super formula or any artificial intelligence-based formula is a grand master of biometry and artificial intelligence being the game changer. Thank you. Thank you for your kind attention.
Thank you, Dr. Agarwal, for giving us a super high concept on IOL calculation. I would just like to have your idea as to where to get the LADAs and the Keynes formula that you are talking about, which has got more accuracy according to you. How do you do that?
What?
the Kane formula and the
Kane formula,
ladder's
yes,
formula.
Kane,
How do you get that?
actually-
Where is it? Is it available? If I want to do it, how can I do it?
No, it is it has come to the website also. It is also has come in the domain. So you can calculate it with that also.
Okay, right. So, is it yeah? This is it in IOL Master or any
No,
other?
no, yes, in one company that has come, most probably
Some.
Alcon or
Achha,
something.
anyway, but it is coming
It
in
is
in
coming
the
in-
in
it is
any
coming
one
in
of the IOL calculating machine. Maybe
calculating
it will be available, right?
It is Kane. But I think that it is happened because validation is much more wide, should be much more wide, and much more investigation is needed. At present, the Barrett calculator for the toric part and LADA super formula or Hill RBF formula for the spherical part is very good combination.
Yeah, that is available in most of the machines. I mean, yeah.
No. That is the problem. Only the problem is that we calculate the variables, and we put the variables into the clouds, and the cloud calculate with the deep learning method. No, it can be lens thickness, it can be ethnicity, it can be the sex. These are the variables.
The only what you're asking basically is the limitation of an optical IOL measuring devices, right? So with mature cataract, I think it cannot be achieved, I suppose. It has to be ultrasound based. So there may be an artificial intelligence device which is based on ultrasound technology.
That is the problem, that only thing that maturity of the cataract is the one problem.
So with the permission of the
okay. Now with this
Chief
we
Inspector,
end this session of artificial intelligence.
Can we all
now just all presenters must come for the photographs.